Good evening and welcome to our first episode of Oncology Radio. Oncology Radio is brought to you by the Physicians of Maryland Oncology Hematology. We serve our patients at our 11 locations throughout the state of Maryland, and we are now bringing you the latest in cancer treatment on Oncology Radio and broadcasting around the world. My name is Dr. Shannon O'Connor, and I will be your host tonight. And I've been with Maryland Oncology for about 9 years now, and I'm certified in oncology, hematology, and hereditary cancer genetics. And I have a special focus in breast cancer, cancer genetics, and also hematologic malignancies. And tonight is our first podcast, and we're going to be talking about a very exciting topic in cancer care, which is cancer care in the era of COVID-19. We'll be talking about how things have changed with our cancer treatment regimens, how our patients have been affected by COVID-19, and then we have a very special guest from the NIH that's going to be telling us about his experience with COVID at NIH and some new exciting research that he just published on a new therapy, possibly for severe COVID infection. So without further ado, I would like to introduce our very special guest, Dr. Mark Roschewski from the National Institutes of Health in Bethesda, Maryland. He is a clinical scientist and the clinical director of the Lymphoid Malignancies Branch of the Center for Cancer Research at the National Cancer Institute. And he has many accolades and publications and is a lead physician in clinical cancer research and research trials at the NIH, focused mainly in lymphoma. So thank you so much, Mark, for joining us tonight and being our first guest on our podcast.
No, I'm happy to join. This seems like a nice platform and a fun way to just talk about, important topics as they relate to you and me and everyone else.
Yes, no, I'm very excited. Well, I don't know if you want to just tell us a little bit more about yourself and what you do over at NIH, and then we can dive right into the show.
Sure. So I'm a clinician, and our team focuses on treating patients that have lymphoma, and virtually all the patients, of course, that are treated at the NIH are treated on a clinical trial. So we treat a variety of different patients. All of our patients are adults, so we don't treat children with lymphoma. We collaborate with others to do that, but our patients have the common lymphomas. Right. So our patients have aggressive lymphomas that need chemotherapy right away, and the goal is cure. We also have patients that have more indolent lymphomas, in which we're testing newer therapies that have some reason to think that they're going to be effective, but the goal isn't cure. And so there's some more, options there as far as how they can be approached. And one of the things that we have been focusing on over the last 5 years or so in a large way is patients that have lymphomas in their brain or various CNS lymphomas. And what we do here is we think about, what are the areas of treating patients that are not well covered by, yourself, like community oncologists, or treat, where are the holes in how we treat patients and how can we improve those things. So we certainly always work closely with people like yourself because, it's important that we identify those holes, and those are the patients we prioritize for our trials. So that's pretty much how we do it. And, I've been in this position and we've been doing this for about the last 5 or 6 years.
Great. Yes. And we've worked very closely with you, and it's been a great relationship, and we appreciate having access to the clinical trials for our patients. So, I guess I wanted to jump into the, pandemic and COVID-19. Have you been seeing patients with COVID-19 infection over at NIH, given that you're kind of a clinical research center?
Yeah, so the answer is yes. The NIH, and specifically the NIAID, so this, of course, is the institute headed by Tony Fauci, has an entire infrastructure here that is designed to take care of patients with these highly infectious viruses. So it starts with things like Ebola, and now it's moved to COVID-19. So there's an entire special unit that's designed to treat these types of patients, and at all times there's some clinical trial testing an agent or a randomized trial for these patients. But our specific group actually doesn't, of course, treat patients with COVID-19 infections, but we recently sort of got into this because it turns out one of the drugs we've been using and studying very closely in patients with lymphoma we had a reason to think it actually might help with these patients with COVID infections. So that's been a really, really pretty amazing story, actually.
Yeah, and I definitely want to get to that in the show, because you just published a really exciting study about these drugs that we use in lymphoma that may be helpful in severe COVID-19. So we'll definitely come back to that. I mean, I guess, as you know, as we all know, our patients in general, our cancer patients, are at higher risk for complications with COVID-19. Have you guys seen a lot of inpatients or a lot of those complications in your population of patients, or?
Surprisingly not. I think a lot of it depends on maybe the types of treatments that one is delivering. Now, many of our patients that are treated here that have CNS lymphomas, their treatment's often in the hospital, and I think that's one aspect. And at least the NIH has put up quite a few regulatory barriers to make sure that they do a good job of screening people to come in and out of the hospital. And since we have this special campus, we don't have an emergency department, so we don't have people coming in off the street, so we have less traffic, if you will, as far as that goes. So we haven't seen a big problem with our patients that are either getting treatment or getting followed, actually getting COVID-19. We've seen it in the area, certainly around us in Maryland. There's been a number of cases, particularly at the beginning of this year, but we ourselves have not seen much of that.
Okay, yeah, you're kind of protected population, like you said. The patients are probably being a little bit more cautious too, and it's a unique center. You have to go through a couple of things to get into NIH, as you said. We're doing a similar thing where we have a lot of checklists and things and temperature screens, and so we also too have not seen a lot of our patients with COVID infection. So that's interesting.
That's good.
It's good. It's good for our patients. I guess there's been a little bit of research, I guess, or speculation on general cancer care in the era of COVID, and whether or not we as oncologists should change our regimens or delay chemotherapy until the pandemic is over. When, I guess early in March, we were doing that a little bit because we didn't know how long this was going to last. But I don't think that's really feasible now that we're probably going to be in this for a while. I don't know. What's your perspective on, treating patients with chemotherapy during this pandemic and their risks, et cetera? The risk of steroid use, that's another big topic.
Yeah, no, I think that's important. So, I guess the way we sort of operate in normal circumstances, we as oncologists, is we sort of constantly are weighing the risks and benefits of whatever we do. And I think when you do this for a long period of time, you get sort of comfortable with certain risks because they're very much known to you. So at least my experience is that because of the regimens we use for lymphoma, we frequently see people with very low neutrophil counts or even low platelets. And since it's so typical from what we do, it just seems like a routine thing. But one of the things that I think happened here at the NCI, and certainly our group, is we sort of just had to scrutinize everything that we do. Not just treatment, but also, tests that we order. And I think because of the nature of this pandemic we're going through, and because of all the uncertainties, simply sending a patient for what's typically a routine test, whether it's a blood draw or CT scan, we really started scrutinizing if we really needed to do that, just because it's so highly infectious, and anything we could do to limit person-to-person contact seemed like a good idea. So that, I'm sure, has been what everybody's been struggling with, because since it's a new disease, a new pandemic, we don't have that evidence we want to think about how we do things. And myself, in the nature of what I do, focusing on lymphoma, I'm used to being well healed on latest research and feeling very comfortable with evidence-based approaches. And here it was almost like there was no evidence. So we spent a lot of time in lymphoma thinking about, well, what are the treatments that can be delayed? Now, a lot of these lymphomas, as you know, when they're aggressive, there's not a lot of choice, right? So since the goal is to cure the patient, we made a concerted effort to keep doing what we were doing for the most part. So in those situations, all of our trials actually that included regimens that were likely to cure patients, so untreated aggressive lymphomas and CNS lymphomas. We did not change accrual patterns for the most part. We continued to accrue to those trials, and the concept was, well, these are trials that are leading to cures of patients, and particularly patients with rare diseases. So we continued to do those things, but what we sort of did is we did much fewer research samples, much fewer blood draws. When it was, optional to do a scan, we sort of said no. We tried to focus on, other ways of assessing response, if you will, and these types of things. So that was one of our main things that we did there. But then if you think about some of these other lymphomas, or even things like multiple myeloma, where there's a lot of situations where patients may be able to go, as you sort of pointed out, months, maybe even sometimes years with no treatment, either at the beginning or even after initial treatment, we basically made a decision to not offer those things or recommend against them to people that were getting treated in the community. So, maintenance therapies, which are typically not associated with a higher rate of cure, but they're more designed to, of course, control the disease for longer periods of time, at least in the short term. We sort of shied away from doing those things. And so that's been the main thing that we've kind of done as far as, how we focus on therapy.
Okay, yeah, that was going to be my question, is like, did any of your protocols get delayed or put on hold? Some of our protocols that were kind of nationally sponsored protocols did get put on hold because of the pandemic, and we were not able to accrue patients. But sounds like most of your protocols were still up and running and accruing. So that's good to hear.
Yeah, we really didn't reduce our numbers very much. And I think that was a little bit unique to our group, just because of the nature of the patients that we have. Most of the groups, I think, at the NCI did put, a lot of their study accrual on hold. And then I think the other thing that has happened in clinical research, cancer research anyway, and it's been helpful to us, is a lot of the requirements, the regulatory requirements, as far as reporting or reporting deviations when you do a lot of those restrictions, which are typically can be very stifling. They were relaxed to some degree. I think the regulatory agencies sort of were sending a message that they understood this wasn't going to be business as usual. I don't think anybody who's lived in 2020 thinks anything's been business as usual. And that's also been true in, cancer research. There's been some, leeway granted for some of these situations when you don't get a study done, a blood test or an MRI, or maybe a patient's coming from out of state. That was another thing we had to deal with, is,
Right.
Certain quarantines associated with crossing state lines. And for the most part, I wouldn't say we've been unaffected, but we've been able to navigate that and still sort of keep, doing at least the studies and the priorities of those that we thought were the most critical to result in, patient outcomes that were positive.
Okay, yeah, the travel is, I'm sure, a big issue because you do get quite a bit of out-of-state travelers to your center. I mean, on that note, I guess my next question was about visitors. I mean, we're not allowing any visitors even in our chemo infusion suite. No visitors allowed in the hospitals at all, even when their patients are very ill and sick and even sometimes, dying. And we've noticed a big shift in, patients becoming, needing more support because they don't have their families there, and they can't have, another set of ears during the appointment. They can't have anyone around if they're not feeling well or need help. I mean, have you guys experienced the same thing in your patient care, or?
Yeah, I would have to say that has been the aspect of the whole pandemic that's been the most difficult for myself and the team. I think a lot of providers, physicians, and nurses have expressed the same thing, is, when you're dealing with this patient population, these cancer patients, delivering therapy is one thing, but really we spend a lot of time, and I know you do too, trying to help them understand what it is you're about ready to do. And it's common for patients to need a large net of people to help them cope. Whether they're in the hospital or outside the hospital. And these restrictions, as far as who can be in the hospital with people, has been a real bear to navigate, because in all situations you would want as many people as possible. And just for protection of staff, protection of other patients, we've also have gone to that where, there can either be no visitors at all for patients in the hospital. And I told you some of our patients have, lymphoma in their brain, so that can be very disorienting. Or in other situations where you allow a patient to stay because they're a primary caregiver, they can't leave the hospital. So
Right.
they can stay, but they can't leave. So it's giving people some really difficult choices on how to navigate this. And that's been a big problem, I would say. Not necessarily because those rules weren't important, but it really makes it difficult. And then there's this other layer of, signing consent forms. Here we are trying to sign patients, consent them onto therapies that in some cases are quite experimental. And it's really, I think we're doing less good of a job in sort of communicating with them what they're doing because of all these restrictions. That's been a problem.
Yes. Yeah, I agree. It's been very difficult not having that family support for the patients. And that's been one of our biggest challenges as well. I guess I want to shift gears a little bit because I do want to get to your exciting research that you've been doing. So you just published something recently in the Journal of Science Immunology about Bruton tyrosine kinase inhibitors in patients with severe COVID-19. So I would love to hear more about that and tell our audience about your research.
Yeah, so this actually is kind of a fascinating story. So, these Bruton tyrosine kinase inhibitors, of course, are commonly prescribed. They're available and they're FDA approved in CLL and mantle cell and Waldenstrom's, and I think virtually all oncologists have used them many times. What we knew that was unique is came to us because of actually some toxicities that we saw on our clinical trials. So about 6 years ago, we had opened a trial using ibrutinib in patients that had CNS lymphomas, and what we found is that it was extremely effective. So even though the patients had lymphoma in their brain, and one might guess that the ibrutinib's not going to cross the blood-brain barrier, it did. And we saw remarkable responses with ibrutinib in patients that had relapse and even refractory disease. But in the course of doing that study, we also learned that ibrutinib, which is, of course, targeting signaling inside B cells, also has an effect on the innate immune system. So what we saw that we didn't understand at the time was we saw that some of our patients, when they were on ibrutinib alone, coupled with steroids, were getting very severe Aspergillus infections. And these were infections of the lung. Sometimes they even went to the brain. And there was enough of them. In fact, we had 7 such cases in the first 18 patients that even though the treatment we were giving was really effective, we had to stop the study. Now, what we did is we stopped the study and we wanted to try to have a better understanding for what was happening, because the idea that a drug that is or what we thought was very specific to signaling inside B cells was causing or at least contributing to these serious fungal infections was really not reported. And so we spent the better part of 3 years working with our colleagues in NIAID. My friend and colleague Mihalis Lionikis was spearheading this research, really doing a deep dive into the innate immune system. So he has a system set up where he can look specifically inside myeloid cells and neutrophils and T cells, and try to have a better understanding for what knocking out BTK is doing. And so we already knew through this research that BTK inhibitors have an effect on the innate immune system, specifically macrophages, and some effect on neutrophils. So we knew that. We knew that because that had caused this toxicity. What happened is we were seeing the reports, of course, the early reports from China and then early on in New York, where the patients with COVID that were getting into the most trouble, the patients that were getting the very severe pulmonary forms of COVID, seemed to have this hyper exaggerated immune response. And not only that, it seemed to be the type of immune response you would see associated with macrophage activation. So things like macrophage activation syndrome, these extremely high ferritins, extremely high CRPs. And of course, I think we've all come to appreciate that the patients that have these severe COVID have sort of a second phase where, there's this initial inflammatory problem, and then even when they recover, you can get a second inflammatory problem, which was, to us at least, was highly suggestive that there's a recruitment aspect, which of course again isolates it to macrophages or the innate immune system. So what we did was, since a lot of the labs here were shut down, we looked into the published literature about, well, how crazy is this idea that, blocking BTK with any BTK inhibitor would actually, block the immune system, the innate immune system, in such a way that you could prevent lung injury. And it turned out that those preclinical studies had actually been done already. So a couple of years prior, and this was, of course, in a bunch of literature that we just weren't familiar with. It was infectious disease literature in which preclinical models of severe influenza in mice, that knocking out BTK in these mice actually protected them from pulmonary failure. So all the mice that BTK was not blocked died, and blocking BTK in these mice actually protected them from lung injury. So there was some rationale that this might work. There was some preclinical models that this might work. And at the time was sort of when Maryland was having a spike in cases around us. And of course, there's no known efficacy. So the only trials that were ongoing at the time was the remdesivir trial. That had not shown any results yet. And I think people were really struggling with anything they could do. It was a tough time. So what we did is we took this rationale and we added to it with other published literature as they were coming out. We continued to kind of tweak the model based on what we learned. And we thought to ourselves, well, if these patients are really getting into trouble with this cytokine storm, and if the cytokine storm at its base is dependent on BTK, then perhaps blocking BTK will prevent the cytokine storm. And what it's doing is that this innate immune system inside the macrophages, there's these known signaling pathways called toll-like receptors. Toll-like receptors 3, 7, and 8 are the specific ones. These signaling pathways were being used by the virus to activate macrophages. And these specific signaling pathways actually are dependent on BTK. And so we thought to ourselves, well, maybe blocking BTK will sort of stop this cytokine storm before it even happens. So instead of really waiting until, the patient's really in dire straits, perhaps blocking it when there's a sign of inflammation early on and lead to better outcomes. So taking that rationale, we knew that there were these BTK inhibitors are available, of course. There's, 3 different BTK inhibitors approved in the United States. And we spoke to our colleagues across the street at Walter Reed. So at the time, we actually had ongoing trials at NIH. And what we were proposing to do was not yet in a clinical trial because we had only recently come up with the hypothesis, but it was actually to have off-label use where, of course, we're used to doing that in oncology where we have a rationale and we think we can improve outcomes. So we give it, to a patient and we talk to them about the risks and benefits. But here we were doing the same thing with a cancer drug. We used acalabrutinib because it's a little more specific for BTK. Perhaps it's a little more safe in the long term. And we proposed of giving it to just a handful of patients, 2 or 3 patients that were in the hospital, had signs of inflammation, were not improving with whatever therapy was being given, and were willing to take this medicine for only like 10 days. So our thought was, like an antibiotic, if you can just shut the pump off, one shouldn't need to give this drug for long periods of time. It's just going to block what it needs to block, and then you can stop it, and the patient can improve. So the very first patient we treated at Walter Reed, we had some oncology colleagues there that that we shared this hypothesis with, and they asked questions and they thought it was at least reasonable. And we identified a patient who was worsening in the hospital. She had just been admitted that day. She was worsening in the hospital and was getting to the point where she needed to be intubated. So she went all the way from a early oxygen requirement to high flow oxygen, 55 liters high flow oxygen in the same day, and did not want to be intubated. And the ICU physician was like, well, he didn't have access to tocilizumab, which was this IL-6 monoclonal antibody that was being used in a similar way off-label in some patients. And he called us and said, well, what about this acalabrutinib? So we said, well, it seems like a reasonable thing. The patient doesn't want to be intubated. That's the next step. And we consented her at like 1 a.m, I think. Maybe it was midnight. And we told her, we consented her by verbally consenting her, right? Just telling her what we knew about the drug, what we knew about its possible effects, which at the time was no patient that we knew of had even had the medicine for this purpose. And she said, well, we might as well try it. So we gave her the treatment, the medicine, and by the next morning, her oxygenation was already coming down. She already felt better. And 4 days later, she was out of the hospital. So, that's, of course, an anecdote. And as a researcher, we know the perils of anecdotes. But it was a powerful one because of just the way I described it, how the patient was clearly getting worse. And it turned around, and it turned around rapidly. And we saw the same thing in the second patient. So the second patient had a similar story, not quite as ill. And we saw the same thing where we saw the inflammatory markers dropping almost immediately after we started it. And the patient felt better within a few hours after starting the drug. So, one of the things I like to say about our job here at the NIH is we commonly start, early studies. We kind of prove hypotheses, prove principles. But then for us to get this out to masses, of course, we need to use people like yourself, US Oncology or cooperative groups or these types of things. And in this case, we actually did share some of these results with some US Oncology group across the country who had access to this drug, and they had patients that they agreed could be tried. And so it was almost like we started a research group on the fly by just sharing information about what we had observed, the rationale, and each individual doctor at each hospital would talk to various patients and ask them if they wanted to be treated. And so in the end, we ended up treating 18 patients, and the results are actually 19 patients, and the results we published last month. So it was pretty. The backstory, I spent some time going into detail there because it's actually pretty fascinating how it all sort of played out.
No, that's amazing. That's actually very interesting, and how just your hypothesis, translated into an actual patient that needed help that was, decompensating, and you were able to kind of activate it that quickly. That's just, amazing. And then spread the word and get more patients. So those 19 patients, so that first 2 that you told us the anecdote about, those are included in the 19 that you published, right?
Right.
Okay.
Right. So at first, when we first were discussing, and this was one of those situations where everybody was working 7 days a week. So a lot of these conversations were over the weekend. We're having calls every day, just trying to make sense of what we were seeing, what we should do, how bold we should be. The last thing we wanted to do was take a drug to somebody that's unproven and make them worse. So we were hyper focused on, selecting patients that were not getting better. And at first, because the drug we were using, acalabrutinib, is oral, we were reticent to give it to anyone who was on the ventilator, because then we'd be having to mix a slurry and put it into feeding tubes, and we wouldn't know if it was absorbed, and the patients would be more ill. But after the first few anecdotes and then a few more started trickling in, we almost thought it's almost unethical not to try, because here we are in a situation where the country's basically at a breaking point, it felt like, where we were going to run out of ventilators. or the healthcare systems were going to break. And so we thought, well, then we have to try. We have to try to put it down, these ventilators, and see if we can improve the outcomes in those patients. So in the end, we treated 11 patients that were not on a ventilator, but had an oxygen requirement. And what we saw in those 11 was almost all of them got better and discharged on room air. So 8 of the 11. And importantly, it was very, very fast. So we saw this happening in a couple of days. And at the same time, we would see the CRP levels drop. So the CRP level was commonly, 20, 25, 30, this is milligrams per deciliter. And you would see it normalize within 3 days. And you would see lymphocyte counts improve over 3 days. And these all sort of tracked with each other. Now, in patients that were on the ventilator, it wasn't quite as dramatic. We had 8 such patients, but 4 of them came off the ventilator. And at least 2 of them, it looks very clear that they were getting worse, and then they got better with the acalabrutinib. But they were still, 4 of those patients that ultimately died. And I think that that's, another area that we're going to look into more. But probably the most important thing about these original data sets and really this off-label study, this proof of concept study, is it was very convincing to the company. So AstraZeneca, that makes acalabrutinib, or licensed it with Acerta, were very impressed with the results, and they took that and they're now doing prospective trials, randomized trials, to definitively answer this question, do it the right way. So, what we were doing was sort of testing an early hypothesis, and we didn't want to test it in too many patients, but we at least wanted to do it in enough patients that we had a sense for the safety. And now and these studies that are being done by the company are done across the world, to include, Brazil and some of these hard hit countries. So that's kind of the most exciting thing for me, is that we kind of launched something that I think ultimately we'll learn in a definitive way whether or not this will actually help people or not.
Yeah, that was my next question, is it going to be a larger trial? But yeah, you just answered that. That is exciting. Is NIH participating as one of the sites, or is it
we are
other locations?
Yeah, we are. We don't have near as many patients, and I think that's the other thing we learned about this whole pandemic, is it kind of tends to move. It's like a whack-a-mole where it just pops up at different places. So right now we don't have that many patients at NIH, but my group and Wyndham Wilson and Lou Stout, who basically are my branch chiefs, and they were the sort of brains behind the whole thing. They're effectively leading that study from an academic point of view. But the majority of patients, I think, are actually coming from, at least at this point, other countries. I think it's going to come stepwise. There's going to be smaller studies, and then if they're positive, which I have a high hope that they will be, then there'll be bigger studies that'll be more definitive. So that's kind of where that's going to go.
And I think you mentioned safety, and in your publication you noted there's really no toxicity of the acalabrutinib and no major side effects reported. So I mean, maybe that's because they were only on the drug a short amount of time, or what do you think about that?
Yeah, well, so that's one of the things I think is the biggest limitation of our analysis, is we were not operating with a standard typical database where people are actually inputting all this data and you can really tease out toxicity. From our look, based on what other doctors were telling us, and keep in mind, here we are working with oncologists who are communicating with pulmonary critical care doctors, who are communicating with internists, who are communicating with all these other specialists. So it was, I don't feel that I have a good handle yet that this is going to be safe. When you get out into large numbers of patients, when you start adding in steroids, I think that's a big question that people have now. Are you going to increase the toxicity when you add steroids to these things? So I think that's one of the main reasons why these trials have to be done in a proper way. But at least from what we saw, it didn't look like anything was related to the drug, and you wouldn't expect that there would be anything unless you were to see maybe some, cardiac arrhythmias or maybe some super infections or something that would come along. But we didn't see any of that. But I think that's going to be, addressed by these bigger studies.
Yeah, I mean, that's great information. And this was really exciting data, really interesting article. And I thank you so much for explaining the backstory. That was really interesting. I don't know. I mean, if you want to transition to like one more topic, I guess a little bit off of COVID, but if you want to talk anything else about your lymphoma research that you're excited about or any new projects that you're doing in the world of lymphoma and hematologic malignancies.
Yeah, we to kind of circle back, we have been focusing on these drugs in these lymphomas for quite a while, and I told you the backstory of how we teased out this fungal infection toxicity that led to our studies in COVID. Well, subsequently, that study has also been amended where we give all patients these antifungal drugs. Now, the reason it took us some time to sort that out is antifungal drugs affect the levels of ibrutinib and acalabrutinib. But we've amended these studies, and now we've treated almost 30 patients with CNS lymphoma, and all these patients are relapsed and refractory. These are patients that have, refractory primary CNS lymphoma has a median survival expectation of only 2 months, and that's overall survival. But we've treated over 30 patients with primary as well as secondary CNS lymphoma that are all relapsed. We haven't seen any cases of aspergillosis anymore. So I think with the use of these antifungal medicines, we've been able to basically make that toxicity go down to very low levels. And the results have been just really stunning. In almost every case, we are seeing these patients with primary CNS lymphoma go into complete remissions. Secondary CNS lymphoma is a little more difficult because they're not always sensitive to these BTK inhibitors. But the patients that are sensitive to BTK inhibitors also tend to go into complete remission. And then it turns out when they're not sensitive to the BTK inhibitors, now we mix these BTK inhibitors with this chemo regimen that we give, but it doesn't look like the chemo is all that effective. It really looks like the tumors that are sensitive to the BTK inhibitors are the most sensitive. So that's been really this year. We've really got a good readout on that, and I think that's been one of the most promising things that we're doing because I think that has a potential to really change clinical practice.
Again, very exciting, interesting research, and I thank you so much for sharing it. And it looks like we kind of have to wrap up our show for tonight, but I do want you to kind of give yourself a little plug, or if you have any other way to get in contact with yourself, or if a patient needs to be referred to you, how do they go about doing that? Give us all your information if you can.
Yeah, sure. Well, so patients and physicians can always email me directly. My email is mark.roschewski, which is roschewski @nih.gov. And what we do here is, our team sort of takes a position that we're here to supplement what's done in the community. So we will see virtually any patient here for a consultation, even if we don't think there's a clinical trial here for them. That can be the form of a second opinion. That can be saying, yep, Dr. O'Connor's on the right track. We agree with her. Do what she says. We'll be here if something relapses. Or in other cases, they come here to actually go on clinical trials. But we sort of take this approach that it's a public-private partnership and that we serve a particular role. We have some expertise, and we can certainly help you. So we're happy to see patients, even if we don't know that they'll go on a clinical trial, and even if we're just a source of information for those of you that see, the majority of people. Let's be honest.
And is it easiest if a doctor, if they have a referral, just to email you, or do you have a referral line or referral nurse that would be good to contact?
So they can actually, that's right. The best way to get the process started is actually called the NCI referral line. So the NCI referral line is 240-760-6050. So they accept from nurses, physicians, patients, and they will just get the process started to get your first appointment at NIH. Of course, patients that are on clinical trials here, their travel back and forth is covered by the NIH, and there's some other, and the care here doesn't require insurance. There's no payment. So there's a lot of advantages for patients beyond just what they might get in the form of a trial.
Yeah, and I can personally say we've had a great working relationship with you and your team, and the patients get great care, and it's very easy to get an appointment with you and your team. So I thank you again for that. And I thank you so much for being our first guest and our first podcast on Oncology Radio. And so if anybody else wants any more information, please contact Dr. Roschewski. And if you need any of my information or Maryland Oncology's information, our website is www.marylandoncology.com. And you can actually get referrals and appointments online from that website. So thank you again, Mark, for joining us. And thank you, everyone, for tuning in. And until next time, that's the end of our show, and have a good night.